come in like, well, I'm glad to hear that. Okay, so when the cuspids come in like fangs, they extract bicuspids and leave it with a small arch. The best thing to do is like the photo in the down below, develop the arch, and I can show you a couple of appliances to do that with very easily. Okay, so how do functional appliances improve the overall health of children by expanding the airway? Arch development's the key. So there's a couple of easy little appliances we use when we start out for patients who are good cooperators. That's a Schwartz appliance on the right and a Schwartz appliance on the left, one for the upper, one for the lower. And what the neat thing is, I didn't realize this when I started to use them, you open up the nasal airway. You convert sometimes mouth breathers to nasal breathers, and that's the key to health. Mouth breathers are your enemy. You have to, mouth breathers cause malocclusion, mouth breathers cause bruxing, they cause all kinds of problems, and you've got to get oxygen, and so you got to open that arch up. There's a picture before and after. All we did was use that Schwartz appliance and expand the upper arch. Now there's room for all the permanent teeth. So all the permanent teeth in this case came in beautifully, and he never needed ortho or phase 2, which is great. Have a look at the lower, and you can see there's only 2 lateral incisors down there on the lower left, and you can see there's crowding. And then I expanded the lower arch, which I showed you with before, the lower Schwartz appliance, and look how beautiful that is. Who do you think can talk better? He's got more room for his teeth, more room for his tongue. Everybody wants a broad smile. Julia Roberts has got the $1 million smile. Everybody wants that. Now we have the one on the left has got a beautiful smile. The one on the right, not so beautiful. I'm not sure if he had bicuspid extractions or maybe they just didn't develop his arch when he was younger. But we want, and I show these pictures to my younger patients and say, who do you want to look like? And everybody picks her. And of course, everybody would pick her too. Jen looks pretty good. So here's a patient. We came in with a constricted arch. Now she's a little older, but I want to show you what we can do. I want you to look at how the teeth are tipping in. Every time the teeth are tipping in, you need to expand that arch. We made the arch wider with upper and lower expansion appliances, and you can see how the upper teeth are going straight down and the lower teeth are straight up, which is what they're supposed to be. And look at the smile. I mean, that just makes you want to go to the office. And the neat thing about ortho is that my team does most of the work. And Dr. Sepp and I go around and supervise and pat them on the back and say they're doing a great job. And we do the diagnosis and the treatment plans, and we present the cases to the patients. But what a beautiful smile. I mean, that is a narrow smile. Look at the black corners of the side of her mouth. And now look at no black corners. All you see is teeth. And look at her eyes sparkle. So on my course, I teach you to treat simple cases, starting in the mixed dentition. Use functional appliances, non-extraction, expand the arches. Mothers love it, and so do the children. They don't want extractions. They don't want surgery. The other thing you can make your children a lot more comfortable and healthy is by moving the lower jaw forward with functional appliances. And look at the before and after. Isn't that unbelievable? I mean, look at the difference. All she did was wear a functional appliance called a twin block for probably 9 months, and that's what she looks like. Look how she's looking down on the photo on the left, and look how she's looking straight ahead on the right, because down they're making fun of her. On the right, she's drop dead gorgeous. She's fantastic. And I know I changed her life. And everybody that uses these appliances are changing lives of patients. So, and when you do that, you open up the pharyngeal airway. Have a look at this. Look at the airway on the left, how small it is. And you can see the patient has a slight overjet, only slight. We used a functional appliance, like a snoring appliance in this patient. This is a snoring patient. This is an adult. And we moved the lower jaw forward, so into an anterior crossbite, which you can do with a snoring appliance because they only worn at night, and all day they would go back to their old bite. And look at the difference in the airway. So remember, when you're moving the jaw forward, you're opening the airway, you're giving the patient more oxygen, you're making them healthier. So early treatment prevents sleep apnea, because when that lower jaw falls back, that can cause sleep apnea and all kinds of health problems. I'm going to show you some of them. The twin block appliance brings the lower jaw forward without surgery. If you take some patients to specialists or general dentists, you shouldn't say just specialists because general dentists do the same thing sometimes. They will recommend bicuspid extractions. And if you do that, you don't improve the profile. When I first got into this, I really did it to improve the profile. I didn't know about TMJ 40 years ago. I didn't know about snoring sleep apnea 40 years ago. And some of you don't know about it today because it's not taught in the schools. You also don't know early orthodontic treatment for children because that, again, is not taught in most of the dental schools in North America. It's interesting, in Europe, functional appliances are used all over the place. GPs use them all the time. But in North America, I believe the orthodontists try to discourage us from treating children, and it's not taught in the dental schools. But look at that difference. Now, one quick thing about this patient, two problems: lower jaw too far back, and second problem, short face height. She'll have a deep overbite. And we move the jaw forward and erupt the lower posterior teeth. We end up with a beautiful profile. Now let's talk quickly about detrimental effects of airway obstruction in children, why you should be doing this. Look at her, severe mouth breather. I mean, this is an old picture. I mean, I don't take pictures in the dental chair anymore. Airway obstruction constricts upper arch. You can see this poor child is having, look, they got dark circles under her eyes. She's got a chronic mouth breather. Her mouth's apart all the time. Her tongue is coming forward to open up her airway. She probably has large tonsils. I mean, you can't ignore these children and just say, well, look, come back when all your permanent teeth are out and we'll fix it. No, it's a functional problem. There's an airway obstruction. It has to be dealt with. Most causes for mouth breathing are enlarged tonsils, enlarged adenoids, and allergies. So our job is to figure out what it is. Our job is to figure out what's the cause of the mouth breathing and fix it. Look at those tonsils. You've got those big, large meatballs in the back of your throat. How could she possibly function normally? She can't. And this picture we just had this patient in the other day, and the part that's circled is, and the circle's a little big, is the adenoids. And if you look down below how wide the black is, and look at the top how narrow it is, the adenoids are completely blocking the airway. Now, the only way we can do it is to take a supplementary X-ray and check it. So that's why it's good to do a comprehensive exam on all your patients and don't miss anything, because that child needs to have the adenoids removed. Here's another one that shows the adenoids, and that's not quite as clear in X-ray, but you can see the adenoids are about 2 millimeters wide, or the airway is 2 millimeters. The adenoids are obstructing the airway. Okay, so mouth breathing causes collapse of the upper and lower arches. When you mouth breathe, your tongue goes down low and causes a collapse of the upper and lower arches. The treatment is to expand both arches. Again, we talked about that. Now, we have some articles here, which I wrote. If you want to make a note of that and ask Lee for those articles, it's a really good article that talks about snoring and sleep apnea in children and the detrimental effects that it has. And I'm going to sort of summarize some of those coming right up. Okay. So I think I missed a patient there. Here he is. Okay. Here's another guy. Came to me many years ago. We didn't have digital cameras in those days. He's a mouth breather. And the thing that's so interesting is his growth has been retarded. He's undersized and he's underweight. And what you need to make a note of is there's no growth hormones. It's kind of obstructing the bottom there. No growth hormones if they don't get to stage 3 sleep. Stage 3 sleep is the third stage where the immune system kicks in and memory and all kinds of health problems if you don't have it. But he has no growth hormones because he's not getting to stage 3 sleep, because he's waking up all the time because he's got an obstructed airway. Now, here are some articles that shows obstructive sleep apnea. They have problems paying attention in school. Their marks go down. They're tired. And the other big problem is ADHD. And we're going to talk about that in a minute. But here's a bunch of articles that say airway obstruction causing sleep and behavioral problems, academic problems, and not good. So basically, this is what we show our patients who have sleep apnea, that when they lie on their back, the tongue blocks their airway. But the same thing happens in children. Their tongue can fall back and block their airway, and particularly if it's large tonsils or they're lying on their back. And the big problem is they can develop attention deficit disorder, and it's related to obstructive airway. That's what the cause is. So again, mouth breathing, enlarged tonsils, enlarged adenoids, snoring causes snoring, sleep apnea. Not good. And of course, mouth breathers have a lower concentration of oxygen in their blood, and that's really important. So here's another article you could get from Lee if you contact her. This was written by James Bronson. He wrote 9 clinical things that dentists have to look for when they're dealing with trying to make them healthy. So this is really interesting. This when I learned this about 35 years ago, I was absolutely astounded. What causes the class 2 malocclusion? Is it hereditary? What happens if you look at the mother and the father and they're not class 2, they're class 1? So the problem is airway constriction of the upper arch, tonsils, adenoids, allergies, whatever, causes crowded teeth, number 1. And number 2, the mandible to go back because the patient can't bite down on their teeth properly when the lower jaw goes back or when the upper arch constricts. The upper arch constricts and then the lower teeth don't fit the upper arch and they have to go back. So the cause of the class 2 malocclusion is airway obstruction. And Edward Angle made that comment in 1901 or somewhere around 1900. It might not be 1901. Look at this patient. This is one of my best patients ever. And you can see she's got a, look at the crease under her lower lip. And look how short her face is. And on the other side, I brought her forward, I think 10 millimeters with a removable appliance, functional appliance, a twin block. And that's what she looks like. So actually she had a Mara appliance because she was over to age 12. And I'm not going to show that here. So how do you diagnose sleep apnea in children? Well, look for a retrognathic mandible because that's blocking the airway. Look for a retrognathic maxilla and the midface deficiency because that means if you're deficient on the maxilla, the mandible can't come forward. Long lower face height, tongue tie. That's something which, boy, we weren't paying much attention to until maybe about 2 years ago. We have a myofunctional therapist now in the office, and she's going to be speaking to you in one of these seminars coming up. And it's amazing how tongue-tied patients they have a constricted upper arch and really serious problems. We had one in today, little guy today, and he can't. His speech has been impaired too, and anyway, and they've been putting it off for years, and finally we're going to get it done. So look for tonsils, look for adenoids, look for mouth breathing, look for the high palatal vault, look for posterior cross bites, anterior open bites. Those things need to be fixed with children and not waited till they become teenagers. Okay, that's what we talked about. Now here's the thing. The constricted upper arch caused the mandible to go back and the condyles go up and back, and we had TM dysfunction. And in dental school, most of us learned to put the condyles up and back when we adjusted a bite or made a denture. Well, that's not where they should be, and I'll show you some pictures to prove it. Look at him, the poor guy. I mean, look at that. How can you even think not to deal with that airway constriction when he looks like that? And if you don't do it, who's going to do it? If you take him to a medical doctor, what's he going to do? He's going to give him nose spray, or he's going to give him something, and they're not taking out adenoids and tonsils very often unless they get encouraged to do so. So the malocclusion is causing the TMJ problem. Again, look at this beautiful profile after we move the jaw forward. So here's the one I want to show you. So the one on the right shows the proper position of the condyle down and forward away from the ear. Because between the condyle and the ear, there's nerves and blood vessels. So if that's back too far, like it is on the photo on the left, you're compressing nerves and blood vessels. Plus, if you look at the photo on the left, the disc has slipped forward. It's biconcave in shape, And when the patient opens, they go over the posterior rim of the disc and they hear clicking. So anytime there's clicking, that means the condyle is too far back and the disc is forward. In younger patients, it doesn't seem to matter as much. But in patients who are a little older, even after age 20, it really seems to catch up with them and they get a lot of serious problems. So we really need to move the jaw downward and forward. And we can do that by expanding the upper arch. Sometimes that causes the mandible to go forward on its own, or sometimes we have to use a functional appliance like a twin block to move the jaw forward. But don't ignore that and don't leave it, because if they go to someone who doesn't use functional appliances, they're going to try to surgically move it forward. But hopefully you won't be in that. You won't be doing that. Let's talk quickly about ADHD. Okay. The medical profession treats ADHD with drugs, central nervous system stimulants, Adderall, concerted Ritalin. And the problem is they cause problems. Here's a couple of articles: long-term safety of stimulants used to treat children with ADHD. And there's all kinds of reasons why not to do it. Some of the side effects are reduced height and weight, cardiovascular effects, tics, which isn't good, and substance abuse. Wow. You don't want those. So again, the medical profession treated with drugs. And what do? We eliminate the cause. We have to go in there and evaluate the patient. What's causing the airway obstruction? Talked about it before: adenoids, tonsils, allergies, nasal problem, and give the patient a new drug. It's called oxygen. So we actually fix the cause of the problem, and the medical profession treats the symptoms with drugs. Obviously, most mothers would rather have the dental option. Look at those tonsils. Wow, those are huge. I call them meatballs, blocking the throat. Now, can you imagine how much airway there is back there? I've got a mirror pushing the tongue down. And that's when I push the tongue down, I get a small airway, but it's really bad news. They have to come out. Okay. So they say that you'll improve the behavior, attentiveness in school, increase level of energy, increase academic performance, increase growth and development, eliminate bedwetting. I mean, all of these things. Imagine if your patient has any of these things, okay? He's doing poorly in school. His mother can't cover him because he's acting up all the time. He's not doing well in school. He's got no energy. He's undersized and he's wetting his bed. Don't you think they'd be very impressed if you said, I think I'm going to look into this, but I may be able to help him? And the way you do it is you take out the adenoids and the tonsils and you expand the upper arch. They call it palatal expansion. And that eliminates the ADHD. There's a bunch of articles there that you can, if you get a copy of this, you can look up, and you'll really see how important it is to develop the upper arch. And we're the only ones that can do it. Nobody else can develop upper arches. And we need to encourage ENTs to get the tonsils and adenoids out because they don't want to do it on a routine basis. So here's an arch we developed, 30 millimeters, expanded them to 35 and straightened the teeth out, and look how good he looks. So remember, the roof of the mouth is the floor of the nose, opens the airway, increases nasal breathing. So watch this. So I tell mothers whose children are struggling to breathe and they're stopping breathing at night and they're snoring to go in and take a video. Look at his stomach up and down, the diaphragm trying to bring air up. The poor guy's got blocked airway, probably large tonsils. And that's an upsetting thing to watch. But you're also, I want you to realize that when you see that stomach going up and down in adults, that brings acid up. And a lot of adults who have sleep apnea, airway obstruction, have acid reflux or heartburn. And that can cause cancer of the throat. No joke. And of course, the poor parents are often sleep deprived because they're worrying about their children choking at night. It's really a serious problem, and a lot of kids have it. And I think we can really help the children in our practice if we concentrate on this and learn how to use these appliances to develop the arches and learn where the problem is. Is it tonsils, adenoids, allergies, nose? What's causing it? How can we fix it? So we kind of talked about that. That's all things that we can do to help those patients. So if you see a posterior crossbite, like this patient's crossbite on the right side, you need to expand that arch. Get rid of the constricted arch. Do not let anybody continue with a constricted arch because you're opening up the airway. That's another one, narrow arch, probably due to mouth breathing, the upper arch constricted. Tongue tie, there it is. What you do is you're supposed to put the tip of your tongue on the insides of a pillow and open as wide as you can. Normally, you can open 50 millimeters incisally. If you put the tongue on the tip of put the tongue on the insides of a pillow and open as wide as you can. If you open less than 25, you're tongue-tied. And you need to get a myofunctional therapist to help you because they can't just cut the tongue tie, the frenum. They've got to do exercises to strengthen the tongue first, then do the surgery. And they do laser now with no bleeding. And then do more exercise afterwards to retrain the tongue. So I've got a myofunctional therapist that you're going to meet in one of these future seminars, and you'll learn a lot. Okay. So the reason the teeth are crowded is because the arches are small. The arches are too small. Now, this is a great book. If you get a hold of this book on Amazon, it's fantastic. Michael Gallup said it affects brain development. It affects brain development, and he's got the proof.
I put it in the fridge. I didn't eat it.
Hello there. So children with sleep apnea, we talked about all those things. Okay. So let's go through. Okay, I guess my question is, the obstructed airway causes sleep apnea. The obstructed airway causes sleep bruxism, where they grind their teeth. Patients are bruxing to open their airway. So my question is, who's going to help these children with ADHD and sleep apnea? TM dysfunction and mouth breathing. I think it has to be you. Some dentists like you with orthodontic training can help these kids. And I can tell you, you'll have a very busy practice. If you solve some of these problems for your younger patients, the mothers are going to appreciate you and tell all their friends, and you're going to be busy. Because we have now 200 dentists and medical doctors referring to us, plus patients referring to us. We're doing very well. We're very busy. And it's all because we developed this philosophy and try to treat the children like this and get results. And people are talking about us and happy with us. 70% of children have a malocclusion, 75%. That's a big number. We start patients at age 5. And it's a functional philosophy, early treatment, develop the arches. In North America, an awful lot of clinicians are doing fixed brace and permanent dentition. And a lot of clinicians have not been trained in early orthodontic treatment. They can't figure out why. It's so illogical not to be trained in early orthodontic treatment. So I'll do a quick case here. Joshua, he comes in, he's got a narrow arch. The key is no room for the permanent central and lateral incisors. If there's no room for the permanent central and lateral incisors, you have to expand. And in this case, there's no room for that on the upper or the lower, so you have to expand both. And I did show you that quick. Now, here's a little trick for you. The distance between the molars in permanent dentition should be 37 millimeters, and the cotton roll is 37 millimeters. So you could stick a cotton roll up there and see if you're wide enough. If you're not wide enough, you should go and expand the arch, particularly if there's no room for the central and laterals. So here you can see cotton roll doesn't fit in there. You got maybe 30 millimeters between the molars in permanent dentition. And look what happened. The laterals come in on the palate. And there's no room. The laterals come in the palate. So why would you wait? Why would you not treat that patient? When you see the patient coming in and between the molars is 30 millimeters, and you know you need 37. Incidentally, children develop 0.5 millimeter a year on their own. So you can do the math if you want, but 0.5 millimeter a year on their own. You can figure that out. Girls stop growing around 15, boys around 17. If you put that cotton roll in there, you better expand or you're going to end up with what you got on the left-hand side there. So here's an appliance. I mean, it's 4-class, 1 screw in the middle. You turn it twice a week. I use 2 fantastic labs in Canada, Orthodont Lab, Bill Van Evans. He also looks after Miami, and 5-Star Ortho, another fantastic lab, Bobby Middle and Andrew, fantastic. They're in there. We do course with them in Dallas and Chicago. So you can't go wrong with those 2 labs. You have to have a good lab if you're going to make these appliances, because a lot of labs don't know how I make them, or even the appliance I'm using. These 2 labs have been with me for, I think, Orthodont 30 years and 5-Star maybe 20 years. So they wear it all the time, except they take it out to clean it and take it out for sports. Turn the screw twice a week. We send you the screw. You put that screw in a little holder there, the hole, and you turn it towards the arrow all the way and take it out. Very easy. They can do this, no problem. So keep expanding. And there's his arch. Started out with 26 millimeters. Now he's 33. Beautiful. He never needed braces. All his permanent teeth came in. Why wouldn't you make room for all the teeth? Why would you let that patient develop with laterals coming in on the palate and cuspids blocked out, and looking at someone who doesn't understand or use functional appliances wanting to extract teeth? You just can't let this happen. You really can't let this happen. Now, if you don't want to take a course from me or somebody else in this, please find a dentist or an orthodontist that you can refer the patients to do this. But I mean, I don't know why you wouldn't do it yourself, because it's pretty easy. Okay. So we also developed the lower arch. So there's the lower arch. I showed you that before. Easier to speak, more room for the tongue. Now there's room for the laterals to come in. Look, the lowers all came in, and we made room for the laterals. They erupted beautifully. And we charged $2,500 for that. And the upper Schwartz, lower Schwartz, and when the records are 500. So, and most of the work is done by the patient. He's turning the screws. I'm not doing anything. I just check him every 2 months to make sure he's opening the screw properly. So it's really easy. And you can learn to do this very, very fast. We teach this in session 1 of our 4-session course. So happy patient, he's got his front teeth. You're straightening his teeth and making his jaw wider, making him healthier, more oxygen, and you're increasing his self-esteem. Now, I've written a great book on this. I've written a book. There's 19 cases in color, start to finish, in that book about the appliance I use to treat children in early treatment in mixed dentition. So I think you might want to talk to Lee Larstone about that and get a copy of the book if you want. Okay, now Jack Trout wrote an interesting book, Differentiate or Die. And of course, he talked about all kinds of things about Kodak film, how, you know, they were almost pretty well out of business when digital came out, because they didn't switch. And anyway, lots of things why we didn't change. You know, the world changes and you have to change with it. And I think mothers today want their children treated early to prevent problems and improve their health and their appearance. I mean, I'm convinced of that because I've been talking to parents for 35 years, and that's what they want. They don't want to wait. And they come find you. If they've been somewhere else that said, wait, they come back and find you. The ladies talk and they'll find you. So just keep doing it. So here's a guy that's a character. See, there's no room for his lateral size at all. He's constricted, very constricted. And he's a poor cooperator. So when we have no room for the laterals and a poor cooperator, he's only 30 millimeters from molar to molar, we've got to use a fixed appliance. So these are upper fixed expanders. You just put them in and they work by themselves. You don't have to do anything. So this is what you want to do. See the patient every couple of months. You put that in. It works by itself. It's a spring loaded appliance. And the spring is in that force module, that thicker part. And if you watch the other, it comes right out and opens it from 4 to 8. And then we kept going. and the lower went from 5 to 9. And so now we've got room for the laterals. And we got no more constricted arch. And now what we do is we put the brackets on. And of course, we teach that. We teach functional appliance and we teach bracketing. But easy cases, do the simple cases. The orthodontists or specialists, they should be given the tough cases. So in my course, I teach you what the easy cases are and the tough cases. One thing I should mention is that as easy as this looks, and it is easy, you should not start a case unless you learn to take complete records. My records, my diagnostic chart is 12 pages long. It's got perio, it's got TMJ, it's got everything in there. Medical history, dental history. I mean, it's complete. And if you have your chart filled out completely, you won't make any mistakes. You'll do everything that's in there. You have to check the tonsils, the adenoids, tongue tie, you check everything. Okay. And also you need to take a cephalometric x-ray if you're going to do orthodontics. And we do teach that in the course. Okay. So these teeth are straight in 3 months. I mean, I think the whole thing took 8 months. 8 months. We used the expansion appliance for 5 months and then put the braces on for 3 months. Doesn't he look better? I mean, there's more room for his tongue. He's going to speak better. And many, many times I've converted a mouth breather to a nasal breather. And you know, you get more oxygen through the nose than the mouth, 20% more. So we made straight teeth. He's up to 35 now. And then we put a lingual bond retainer up there to make sure the teeth don't move after we take the wires out, after we take the brackets off. So I charge them $3,500 for upper and lower fixed expanders and brace on the front teeth, and records $500. Would you not pay that for that case? I think you would. The mothers have no problem. And he actually went back and had braces done for a very short period of time. I did 85% of the work with the functional appliances. So, and the braces on the front teeth. Easier for him to speak. More room for permanent teeth. Don't have to extract teeth. Beautiful smile. See, he's a little character. See, when you see a guy like that on the left, you're going to know that you need functional appliance. You need a fixed appliance on him. Most boys need fixed. Girls will do whatever you want them to do. So that look, that's phase one corrected. I mean, look at him. He looks fantastic. I put the brackets on for 6 months and he was done. Mother very happy. So I wrote the book, and there I am showing some patients the book. Because if you have a case that you have come into your office and you find a case in my book that's very similar, show it to the patient. Say, look, here's a case just like yours. We can do it. There's a beautiful scene in Hawaii, trying to hit a golf ball on that green. I'm about one out of 5, maybe. The rest of the time it's in the ocean or in the bushes. So functional appliances. Remember, when you have a patient with an overjet, you got 2 choices. You can either use a functional appliance to bring the jaw forward and correct your overjet and your class 2 molar relationship, or you can end up with nice full maxillary lip, wide arches, broad smiles, healthy jaw joint. Or I'm going to show you at the end the retractive orthodontics when you take out the bicuspids and pull everything back. So when the patient comes in, I have them bite on their back teeth. She's got an overjet. I now have the mother take out her camera, her phone, and take a picture. Then I bring the jaw forward and have the mother look again. Now, which would you like, mother? And usually she says, I like that picture better. So I said, take that picture and show your daughter, and take that picture home and show your husband. And you'll see that that's what we want to do. So you need to, when the patient comes in, they might be going for another opinion somewhere else. You know, some of them go to orthodontics for another opinion because they know orthodontics do orthodontics. So anyway, so you need to make sure the mother's convinced that they're in the right place. And I tell them, look, if you go somewhere else and they're going to move the jaw forward, I'm okay with that. But don't go anywhere and have them take out her teeth. Okay, so mandibular advancement. We showed you that before. Showed you the airway opening up when you bring the jaw forward. See, here's a snoring appliance. See how the snoring appliance opens the airway, brings the jaw forward. So snoring appliances bring the jaw forward. That helps prevent snoring and sleep apnea. And when you bring the lower jaw forward, like I showed you before, you'll also fix the temporomandibular joint problem. And 1/3 of the population has TMJ problem, TMD. 1/3. And it's not taught in medical school or dental school or specialties. It's absolutely astounding. When I tell patients that, they can't believe it. Anyway, highly recommend you start with the ortho course and learn functional appliances and learn how to help patients, early patient treatment, and then gradually get into adults and gradually into maybe learning how to fix the TMJ. But at least in the course I teach, you're going to learn how to fix the TMJ and prevent TMJ in adults when you treat children by expanding their arches and moving their lower jaws forward when they're retrognathic. Okay. So let's show you again. We use the twin block to bring her jaw forward. She looks so much better. Here's a little twin block case for you. This girl came to me at age 8 with headaches. Wow, look at her eyes. Does she look happy? No, doesn't look happy. Imagine if this little girl walks into your office. First of all, how are you going to know she has headaches? She won't tell you. Nobody goes to the dentist and says, I got headaches. They just talk about their teeth and gums because that's what we've trained them to think about. Got a retrognathic profile, a bit of a mouth breather too. So expansion of the arch, bring the jaw forward might really help her. So overjet is 6 or overbite's 5. Okay. So if you leave her like that, she'll be 14 or 15, 20 years old, same thing. There's no change. Things do not change on their own. Okay. Class 2 molar relationship, retrognathic manual. Here, look, I fill this out for every patient. Daily headaches. Mother brings Alicia home from school due to headaches. She's missing a lot of school. A lot of school. Poor girl goes home and locks herself in the bedroom. And it's because her jaw is too far back, like the slide on the right. The jaw is too far back, pushing on the nerves and blood vessels, and she's in a lot of pain. She got headaches all the time. So I take the twin block and move her jaw forward to the photo on the left, and it gets rid of her headaches. And it improves her profile and opens her airway. Wow. Unbelievable. The first time I started to use twin blocks 40 years ago, I couldn't believe it. I couldn't see how an appliance like that could do it. I'll show you the twin block in a second. What I'd like you to do on every single patient that comes in your office is use this TMJ health questionnaire screening form. Talk to Lee and we'll send you one. And I'd recommend you hand that to every single patient. Doesn't matter how old they are, and you'll find out if the patient has an existing TMJ problem. If they have an existing TMJ problem, you want to start applying the principles I've talked about. Develop the arches, bring the jaw forward with a splint or a twin block or something, and don't retract. Don't move the front teeth back. Move the lower jaw forward. Big difference. So just to show you, an MD wanted to put her on migraine medication. I used to have the MD's names there crossed out where they were. One was in Burlington, one was in Hamilton. History of migraines. Okay. Can you imagine an MD? Oh, they have no training. They don't know. They wanted to put her on adult migraine medication. The mother told him he was crazy. Two of them, one told, anyway, left them, came to me. That's a twin block. It looks like quite a contraption. I admit it. The block is about 5 millimeters thick. There's an upper block and a lower block, and it's interlocked at 70 degrees. And when you go to move your jaw back, you can't because the lower block hits the upper block. You can see right there behind the E on the lower. You can see the division. Now here's how it works. It's kind of neat. This is a slightly different design, but first of all, you have to expand the upper arch. You have to expand the upper arch first before the twin block will work. And there, see how the teeth fit together? The patient can't bite any other way unless their lower jaw bites in front of the upper jaw. So you have to expand, or you'll move the lower jaw into a buccal crossbite. So you have to do that. So that looks good. Now remember, you've got a deep overbite. So now what you want to do is you want to get the lower teeth to come up, and they will come up on their own in mixed dentition without an elastic. Now she looks pretty good. No more overjet, no more overbite. Sometimes had to put the brackets on for a short period of time and finish the case. But 80% of the work is done with the twin block. The bracer, 20%. There's the upper block. You can get a different color. The labs will give you a color. I think that's a glow in the dark with an alligator on there, or a turtle. Maybe it's a turtle. Anyway, that's the upper block. There's the lower block. Remember, the lower block don't cover the lower molars because they have to come up to correct the deep overbite. But there it is. They started out with that large overjet of 6. In 7 months, the jaw's forward and it stays there. Believe it or not, you cannot push that jaw back. It's unbelievable how that works. There's the twin block. It looks like a ball. I guarantee you they'll wear it for 2 reasons. Number one, they look better and everybody compliments them. And number one, gets rid of their headaches. So why would they wear it? Okay. Well, I mean, we treat patients with retrognathic mandibles and TMJ problems, the same thing. We use splints to bring the jaw forward now. But children, we use twin blocks. Are you going to wait until the patient's 17 and do surgery? And he has to wear braces 17 and 19? Or would you put this in for 7 months and fix them? No question what you need to do, right? There she is at the end. Look at her face. Look at how happy she is. Look at her profile. Look how good it looks. No more mandible back, no more short lower face height. She looks fantastic. And that's what makes you want to go to the office every morning. That's why I'm still working. Still working. People say, why aren't you retired? No, still working. Still having fun. Still changing lives. And that's what I want you to do. I was complimented recently. I was really overwhelmed. I was over in Barcelona, Spain with my partner, Sepp. And there was 80 dentists there, and there was 41 or something from Canada. And I would say about 20 of them, maybe 25, came up to me and said how much they liked my courses over the years and how much they've learned and how much they've helped so many patients. It really made me feel pretty good. So I definitely have to keep teaching. And my partner, Sepp, is teaching me now. He's very good. You'll see him next time. He's talking about TMJ. Don't miss that because he's really got a good handle on it. We're helping a lot of patients. But look at the difference in the eyes. Look at the difference in the whole thing. I mean, she's set now. No more headaches. She can stay in school. She's happy. She looks better. Feels better. Headache's gone. That's another picture. I love Hawaii. Okay, I showed you her, I think. So functional appliances, advance the mandible, open the pharyngeal airway. Okay, I showed you that, how it works. And you can see the jaw's coming forward and helping the TMJ. That's the thing you got to realize. When you bring the lower jaw forward, you get rid of temporomandibular joint dysfunction. If you leave the condyle up and back, you don't. We're very fortunate in our office. We take x-rays of the TMJ, but you don't have to take an x-ray. Just move it forward. How do medical doctors treat TM dysfunction? Pain medication, laxants, anti-inflammatories, not spelled correctly, depression, medications. They treat the symptoms. They treat the symptoms. They're not dentists. They can't put appliance in the mouth and do anything. They treat the symptoms. What do? We eliminate the cause of the TMD dysfunction by expanding the arches and bringing the jaw forward. And if there's an airway problem, taking out the tonsils and adenoids and eliminating bruxism. That eliminates bruxism when you do all those things. Okay. Nice profiles. Nice profiles. I guess my question to you is, and this is going to be a toughie for you. Did you go to dental school to only treat teeth and gums like I did? I went to dental school, graduated a long time ago, 58 years ago, in fact. I graduated 58 years ago. And for sure, the only thing they taught me in dental school was to treat the teeth and gums. And so I called the drill, fill, and bill because I was doing fillings most of the day. Today, dentistry is much more interesting with implants and so many more things we can do. But anyway, I guess I'd like to ask you, are you happy with just treating the way you were trained? Or do you want to get out there and maybe expand your horizons and get into maybe helping kids get healthy? I hope you do, because you're going to feel a lot better about yourself and your practice, and your patients are going to really appreciate you. You want to be appreciated. I've never been thanked in my life for a filling. However, if I bring the lower jaw forward and make them look fantastic, or I expand their upper arch so they don't have the extractions, turn them into nasal breathers so they're happy. I mean, we get compliments all day long, especially with our TMJ cases too. So, did you go to dental school to help improve the appearance and improve the overall health of your patient? I hope so. If you haven't, I hope you're going to think about it. And whether you take my course or some other course, just concentrate on trying to help your younger patients get healthier. Last thing, retractive philosophy. Okay. This unfortunately is still being used a lot in North America. You can see the model, overbite, class 2 molar relationship. Many orthodontic clinicians do not use functionals. I don't know why, but they don't. I don't think it's taught in a lot of the programs, and it's certainly not taught in our dental schools. So what they do is they take out the upper first bicuspid, and you all know this because you've sent cases to many specialists and other general dentists maybe, and they've told you to take out the bicuspids. I hope you're not going to do it anymore because you're retracting the maxilla and the upper lip goes back. And I show you some pictures of a patient. The smile is narrow because they've taken out 16 millimeters of tooth structure and no improvement of team dysfunction. In fact, you make it worse. Sometimes you cause it. Unbelievable. Okay, an orthodontist was lecturing recently at an Airway conference. I won't tell you where. And his lecture on was malpractice to extract bicuspids. That's what he said. Malpractice to extract bicuspids is malpractice in his opinion. Okay. So I'm going to get a hold of his presentation. So look at the face. Look at the concave profile. Look at the upper lip back. Upper lip goes back, nose goes forward. And the big problem is that causes snoring and sleep apnea, and I'm going to show you why. So here he is. Great looking guy from the front, not so good looking from the side. Teeth are all worn down. I mean, he's grinding his teeth. Now, I used to think it was stress. I now realize that when your airway's blocked, you move forward at night to try to open up your airway. The term is now called sleep bruxism. So when your upper lip goes back, your nose gets longer. You cause TMJ problems and you cause snoring and sleep apnea. So when you're taking out teeth, you're not only damaging the profile, but you're encouraging temporomandibular joint dysfunction and obstructive sleep airway. Obstructive sleep apnea, sorry. Okay, so they take out 16 millimeters of tooth structure on the top and the bottom, ending up with a narrow arch, which you don't want. No room for the tongue protrudes and you get sleep apnea. I'll show you. Okay, close the airway. So bicuspid extraction closes the airway. We're trying to keep the airway open for a lot of reasons. So another sign of team dysfunction would be bruxism, where if it sets on the teeth. Remember, the condyles go back. When you take out bicuspids, the condyle goes back because you're putting everything back. You're retruding everything on the upper. Instead of moving the mandible forward, you're retruding things. Severe bruxism. Patients bruxed to open the airway at night. When I found that out about 15 years ago, I was amazed. Really? I always thought it was stress. No, no, not stress. Patients are bruxing to open their airway up. Check them. All these patients snoring. Get a sleep study. They got sleep apnea. So we decrease the size of the lower arch and the tongue falls back. Obstructs the airway, causes snoring, sleep apnea. There he is. Now, he had 4 teeth taken out. Do you think there's enough room in his lower arch for his tongue? Absolutely not. Look at the tongue overlapping the posterior teeth. So when he lies on his back, you can imagine where that tongue goes. It goes right to the back of his throat, blocks that airway, and is causing snoring apnea with him. He came to me because he had snoring sleep apnea. He had some minor TMJ problems in this case, but major sleep apnea problems. I got a hospital sleep study on him, and he had severe sleep apnea. He was stopping breathing 31 times an hour. There's only 60 minutes an hour. He's stopping breathing every 2 minutes for 10 seconds or more. Now, this is why you got to treat this. Untreated severe sleep apnea can decrease your lifespan by 10 years. How do you like that one? Increase your risk of high blood pressure, heart attacks, strokes, type 2 diabetes, cancer, dementia, and Alzheimer's. Anybody want any of those? I don't think so. This is serious business. It really bothers me that we were not taught this in dental school. It bothers me that we're not enough of us are taking courses on this to help our patients. 50% of men snore, and women after menopause snore like crazy too. But I mean, all these risks, these are all affecting your health. Bad news. We got to do better as a profession. So what I did is an oral appliance, like a twin block, called a dorsal appliance or Sondadent. You just have a big dorsal fin there, and behind that is a piece of plastic, and you can't go back, and you want to go forward, you turn that screw, and the jaw comes forward. Prevents bruxism, prevents sleep apnea. We have to do another study to check whether the appliance is working or not. And I took him down to 7.7. So I took him from 30, what was it, 36 or 37 or 35 down to 7. Okay. So remember, we talked about the TMJ, compressing nerves and blood vessels. When you don't bring if you move everything back, this is what you get. So if the patient clicks, they need help. And I wish I had time tonight to go into the types of splints to use, but never, never, never use a flat plane night guard on a patient who clicks, because I've had several patients lock on those. You really shouldn't use a lot of Invisalign either on patients who click. You should, because it's a flat plane splint also, and you need to get the TMJ fixed first and then do your Invisalign. Okay, one last thing. Just what if you expand the lower arch? Watch what happens when the tongue goes forward. There's my constricted upper arch. Cuspid blocked out badly on the left side there. Okay, look at the tongue, it's back. Use an appliance that these great labs I work with made. It's a nickel titanium coil spring. You don't have to do any adjusting. It works by itself. Then I use a Schwartz plate on top of that. I open the upper 10, the lower, I think 11 or 12, 11. And that's what she ended up with. Okay. Look at the difference in the arch and look at the difference in the tongue. Look at this tongue way back on the side on the left, and look at the tongue down and forward, fitting in the mouth. It fits in the mouth. I mean, doesn't it make sense to make enough room in the mouth for the tongue? Doesn't it make sense to make enough room in the mouth that you don't have to extract teeth? I mean, this is so sensible to me, and yet an awful lot of the profession have not figured this out. But again, if you figure it out and you do it, you're going to be busy. You're going to love your practice and you're going to be busy. So we showed that again. So again, I think it's great. Opens the airway. You can even get rid of sleep apnea sometime by doing this. And snoring. Proves the speech, they can speak better. Why should you start offering this? I guess we're done. I guess to improve the overall health of your patients. Are you interested in teeth and gums? or you're interested in improving the overall health of your patient, particularly young kids with ADHD and sleep apnea and all their problems. And we showed you that. I guess I'll end on that. Okay, it's 5 after. We'll end on that. This is my favorite case ever. I took her. You can see. Look at the corners at the side of her mouth, and they called her bucket beaver. She had an overjet of about 10 millimeters, and her lower jaw was way back. And I expand her arch, and she's 10 on the left, and she's 15 on the right. And she came back after the braces were taken off, I think 2 years later, and said, "Guess what? I'm a model." She's a model. Would you ever expect it? That little girl on the left could ever be a model. But who has to do it? Only us. We're the only ones that can do that. We're the only ones that can expand the arch, and we're the only ones that can bring the lower forward. Nobody else. So those children, I think, are depending on us. And I'm hoping that I've helped motivate you to look into this and take some courses on this and learn to help the patient. And I believe you will be so satisfied. You'll feel so good about your practice. I love my practice because, first of all, the staff do most of the work. That's fantastic, you know, and I like to help patients. And you do too. You went into dentistry to help people. And you're helping them with their oral health and all that, fix their teeth, but now you can work on the rest of them. Okay. Well, I guess I'll end it there. And thank you for listening. I've had a great time presenting. And I guess I'd be happy to take some questions now, Lee. So do you want to bring up some questions, Lee? Are you still awake back there?
I am. I'm right here. I am still awake. Yes, absolutely. So yes, that's great. I actually do have 1 or 2 questions here. One of them is, what age do you not be able to expand? I mean, the arches.
Any age. You can expand everybody unless they've been in a cast and their sutures are locked. But most patients, I've been able to expand for 35 years, all kinds of adults. If you don't believe me, check with those 2 labs and find out how many appliances they make for adults, all kinds. So your suture's not locked till you're dead, except you've been in a car accident. Sometimes it's locked. But I mean, you can expand at any age. Any age.
Okay. And then another question too was, can you put braces on deciduous teeth?
Yes. Yeah. The tooth doesn't know whether you can do it on deciduous teeth for sure. And lots of times what we'll do, if I had to tell you how I've got a dentist that took my course. He came to my in-office course too. And he's making a fortune just expanding arches and putting brackets on the 6 front teeth and using a permanent cuspid on his primary cuspid. And his practice is booming just with that. I mean, that's so easy. Put the appliance in, expand the arch, straighten the front teeth, you're done. And he's charging, I'm 33,000, 3,500 or something. And they're lining up to come in. And now he's expanding, of course, but that's how he started. And there's lots of patients in your practice that have narrow jaws, they're mouth breathers, and you need to expand the arch. And you also need to straighten the front teeth because mother wants the front teeth straight, right? Mother is interested in having the jaw made wider so it's a nicer smile. But when the front teeth are crooked, those mothers want those fixed. So you're better to learn a little of both.
Okay, and then just one more final question. How early can you start treatment? I mean, from 5 years old, you need teeth, right?
I like it around 5 or 6 because I can talk to the child and reason with them and they understand what we're doing and use fixed appliances on them. I mean, it's pretty hard for me. I mean, I don't know how those pediatric dentists do it. I mean, they get these kids in their chair and start to do stuff at age 3. I mean, that's pretty hard for me. I'm much better with a 5 or 6-year-old I can talk to and understand. They're very cooperative. But use fixed appliance on the young kids. because they don't, if you put a removable appliance, they'll take it out. Put a fixed appliance in, they'll leave it in, and it works by itself, and then take it out. And mothers want the fixed appliances too. They don't want to have them lose appliance or anything, but 8-year-old girls are your best patients. I've never met an 8-year-old girl that wasn't so smart and so motivated to do anything you say. I tell people that girls start out smarter than we are. There's no question. But I really think I'm catching up. I don't know if I'm there yet after 58 years of practice, but I'm getting there. I'm hoping I will get there. I see Jamie smiling over there. Thanks for staying in so long, Jamie. So anyway,
okay, well, that's pretty much it. Everybody, thank you very much for being here. Thank you, Dr. Rondo, for the lecture. It's fantastic. As always, everybody that is here will receive CE. It won't be until Monday. I do apologize. We are going out to Newark for our level 1 course, so I won't have access to the computer here. So I will get those out for you on Monday. As well, everybody will receive a recording of this. So for those who had issues, and I know there was one who had issues hearing, you'll be able to hear it when you get the recording. So again, thank you. And everybody that's in here will be given to the next upcoming webinar and for the entire summer series.
are you the manager of Rondo Seminars?
Yes, I am.
Did you remind them to go on the website and look up all the courses on the website and tell them about the
You know what?
codes?
Everybody should go on the website, rondoseminars.com, and look up all the courses. I'm also very happy to send you the brochure as well. So I'm
Thank
available
you,
at all times.
thank you very much, Lee.
You're welcome.
Thanks for all your help, Lee. Anytime I try this on my own, it doesn't work. Every time Lee's my good luck charm. So thanks everybody for taking the time to listen, and I hope that you picked up some good tips tonight. So that's great. Thanks again. Hope to see some of you in the future. Okay.
All right.
Good night, everybody.
Good night, everyone.
Night, Jamie.